Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Sorry, ada kesilapan teknikal. I was not given this link. I was given a Google Meet punya link. Tapi sebenarnya salah link. Okay, fine. Let's everybody here. Group 1 kan? Sekejap. Group 1 ke group mana?
Group 1.
Group 1. Okay. Fine. Let's start with Umar Kitab Al-Fatiha. Okay, so same kind of rules from yesterday's. It's a two case discussion for to be discussed. One person will lead one case, and then obviously you can ask your colleague if you're stuck or if you want interaction from your colleague. So I'll leave it to, is it Madia? Madia is going to lead the first case.
It will be me.
Okay, now Pais. Okay, fine. There you go. The floor is yours.
Okay, Bismillahirrahmanirrahim. So first of all, let us look at the case scenario given. In case 1, okay. Ehsan is seen in the pediatric clinic with his mother. He is 12 years old, was born in Burma and moved to Malaysia as a refugee 3 months ago. He was diagnosed with asthma when he was seen in the A&E department 4 weeks ago on the basis of chronic nocturnal cough. Today, his mother is more worried about the fact that he has been losing weight and has a poor appetite. Ehsan is using a salbutamol and beclomethasone inhaler, which have not improved his cough. He has been to school. He lives with his mother and 3 younger siblings in a damp 2-bedroom flat, and his mother has also been coughing a lot over the last month. His father died last year. They are uncertain which immunization he has received, but he was healthy before coming to Malaysia. He had been feeling too tired to play games with his sibling for the last 4 weeks, and he finds that his clothes are all much looser. His mother said that he sometimes feels hot, but he has not measured his temperature. So based on this scenario, is there any phrases that you everyone here does not understand? No, okay, everybody is already understand with the scenario. So first of all, let us point out the main key phrases or statement. So first of all, okay, he is Ehsan, 12 years old, came to Malaysia from Burma 3 months ago. Okay, 12 years old, and then went to Malaysia as a refugee 3 months ago, and then 4 weeks ago, he diagnosed with asthma in ED. And then today, his mother is more worried, which is the chest complaint with losing weight and has poor appetite. Okay, and then furthermore, he also that the medication that he get, which is the salbutamol and beclomethasone, has not improved his cough. Okay, and then the others, then we have not been to school, live in a damp 2-bedroom flat, coughing, and also his mother is also coughed over the last month. And then it stated that his father died last year. So we don't know whether the death of his father related to this case or not. So we can ask him further questioning. And also, this another point is the immunization. He does not. The mother claimed that he does not uncertain whether the immunization is complete or not. Okay, and also he also saw sign of lethargic because he feeling too tired to play game with his sibling. And then so sign of no weight gain as he has his clothes are much looser. Okay, and also there's a sign of feeling feverish, but don't know who. So based on this scenario given, maybe we can give a few of differential diagnosis that can lead to this this complication, this chief complaint, which is the weight loss, which is the weight loss, losing weight and poor appetite. So, any suggestion?
Faiz, I think I would like to offer acute exacerbation of asthma secondary to pulmonary tuberculosis.
So first DDX by Sister Wajiha say that acute exacerbation of asthma secondary to TB.
PTB, pulmonary
PTB.
TB. Because of the fact that patient has chronic cough and also loss of weight and poor appetite, and the evidence of the clot Biojudia maculonga too. And then the mother also have symptoms of coughing as well over the last month. And the immunization status is also uncertain. What do you think?
So it's possible. So any other suggestion, everyone?
Before that, I want to ask further about this patient. We need to assess his asthma control, because from the statement, he said that salbutamol and beclomethasone doesn't improve his cough. So we need to assess his inhaler technique. The risk factor of this patient is the risk factor being cut off. So that make him worse for the last 4 weeks.
So we
So
need
we
to
assess the asthmatic status. The asthma status.
we need to know whether he undergoes proper technique or not.
And then his trigger.
Okay. And also the trigger for his coughing, right?
Yes.
Okay. Carry on. So while you discussing about the differential diagnosis, just think back again. Do you guys agree with that suggestion of asthma exacerbation due to tuberculosis, pulmonary TB? So while you're still discussing, think about that statement. Try to reflect that statement with the case. Okay, so carry on with your discussion, Faiz.
So, okay, we already discussed another, how about another DDX? Okay, aside from acute asthma, and any others? Suggestion?
Can it be cystic fibrosis?
Okay.
But in cystic fibrosis, patient doesn't lose weight. Patient cannot, dia failure to thrive. Doesn't gain weight instead of lose weight.
Alright.
From what I understand.
I think we can add GERD, gastroesophageal reflux disease, because the patient also have a chronic nocturnal cough, because the only disease that can cause nighttime cough is asthma and GERD. So I think we can add the DDX GERD in our DDX. And also the cough has been chronic about 4 weeks ago. So I think that is good DDX for this condition.
I would like to add some DDX. I think it could be chronic bronchitis, because usually chronic bronchitis it can present with prolonged cough more than 1 month, and usually chronic bronchitis can caused by viral infection, and in this patient I think it has risk factors because her mom's had the same similar symptoms like cough, right? And then chronic bronchitis actually can associated with asthma patient. Yes.
So how about to make it more organized? We can organize it based on system. So respiratory system, we have acute asthma, exacerbation of acute asthma secondary to PTB, then cystic fibrosis, and then chronic bronchitis. Then there are also another system which is GERD, gastrointestinal. So maybe we can add in another system. How about endocrine? Any ideas, anyone? Any other system? Or you want to proceed with infection, another infection, right?
Can he present with like congestive cardiac heart failure? Because he have chronic nocturnal cough, usually during night, maybe because he was like lying down, so there will be chronic nocturnal cough because of the lung effusion. Because of nocturnal cough, and then he also have lose weight and pure appetite, and also like he have feeling too tired to play games with his sibling for the 4 weeks. Kita tak tahu lah betul tak.
Boleh rasanya.
But he also used salbutamol and inhaler but not improve his cough. So that's one of the DDX lah.
Okay. Any other suggestion? Anyone?
Big name.
So based on this statement, what we need focus on is this, right? His underlying asthma and also his immunization, right? Uncertain whether he received the immunization based on the schedule or not. Okay. So maybe you can add any other infection that may be due to unvaccinated, that prone to unvaccinated children. So if there any idea? So maybe based on my DDX, it has pertussis, acute, maybe due to pertussis. So pertussis, because maybe he doesn't have a vaccination yet, detect yet, okay, because he is from Burma, right? Refugee from Burma. So maybe he has pertussis. Even though pertussis is more to the pharynx, however, based on my reading, that it can also lead to opportunistic infection, such as Streptococcus pneumoniae. So maybe due to that. And then Streptococcus pneumoniae, due to more complication, lead to a more exacerbation of his asthma, underlying asthma. That's why he doesn't, the asthma does not improve during these 4 weeks.
Okay. I want to ask Faiz. Just like you said, pertussis usually common in patient who younger than 6 months, right? This patient is 12 years old boy. Is it still possible?
Oh, I'm sorry, I don't know the common age group which is more likely for the children to have pertussis. But this is my DDX, so maybe we can cross it out. Just a suggestion.
About the statement, he was diagnosed with asthma 4 weeks ago on the basis of chronic nocturnal cough too. It means that does he really have the symptom of asthma like breathing or or chest tightness, because it just on the basis of chronic nocturnal cough. Is it can be used to diagnose asthma?
Based on my understanding from my reading, how to diagnose asthma is more to clinical, because there are many, you need to have certain symptom and also do a pulmonary function test to diagnose whether the patient has asthma or not. So,
because he already 12 years old, I think he can actually use the pictometer, right?
You can also he can use the peak flow meter and also the spirometry, right, to know his pulmonary function test, whether whether the ratio is more than 80 or less than 80, right, to know whether he has asthma or not. So maybe we can ask him.
Because he using salbutamol and the beclomethasone inhaler also not improve his cough.
So now, Ishman tried to put the doubt in yourself whether this is really asthma or not asthma, isn't it?
Yeah.
Is that why? Is that your agenda at the moment? You're putting the propaganda that this is probably not asthma, isn't it?
Yes.
So ni propaganda daripada Ishman. So do you guys agree with him? Adakah korang dah dihasut oleh Ishman that this is not asthma? So do you buy that is it asthma or not asthma? Because you guys keep saying underlying asthma. Faiz keeps saying underlying asthma, and then the first statement about asthma exacerbation secondary to PTB. So has this child got asthma? So think about it. Okay, so there's a chronic cough. So there's three problems here: chronic cough, lose weight, and other one is what is the other one? Lose weight, cough.
Poor appetite, doctor.
And poor appetite, isn't it? Okay. So you also want to know whether what does what does they means by poor appetite? Is it because he cannot swallow? Or has he got dysphagia? Is it because he got any abdominal pain, or is it got any diarrhea ke, constipation ke? Is that lead to poor appetite? So poor appetite is a very superficial statement. So you want to know further information about poor appetite. Is it because he just has no appetite to eat, or ataupun ada benda lain yang menyebabkan dia rasa tak selesa nak makan kan? So there's few more things that you need to think about. Obviously, you need to have your differential diagnosis to ask this further question. So let's go back to cough. Okay, so this boy only coughed at night, and then he presented 4 weeks ago to ED, and the ED diagnosed the cough on the basis of chronic nocturnal cough. Chronic nocturnal cough. Let's say they ada cough for 3 months because he's been refugee to Malaysia 3 months ago. His first presentation to ED was 4 weeks ago. Okay, that's the statement there. So let's say the cough there 3 months. First presentation to hospital was ED 4 weeks ago. And then the next important statement was he's been on salbutamol, he's been on beclomethasone, which has not improved the cough. So is this asthma? Okay, regardless whether vaccination dia uncertain, father dia died last year, dampen bedrooms, flat and so on. And siapa cakap semalam? Yesterday kan, the definition of asthma, I think Safura yang bagi definition yesterday kan. I still remember what happened yesterday. Oh my God. Safura is not in this group, so I cannot ask Safura. So I'm going to ask other group member, what was the definition of asthma? Let's see if I can. Aina lah, Aina lah. Mana Aina?
Bukan group ni.
Aina bukan group ni eh? Cik tak ngaku. Okeylah, bagi Afifah lah. Definition of asthma.
Asthma is a chronic reversible airway inflammation, a chronic reversible large airway inflammation.
Chronic reversible large airway, chronic reversible condition of the large airway. So, and then the reversibles means that it is responding to the bronchodilator. Okay. If this child has been on the bronchodilator and then it's not responding, so it does not fit the criteria of asthma, isn't it?
Yes.
Faham kan? Okay. I'm putting the agenda, the propaganda. This is my propaganda, so that you need to accept this doctrination of asthma. Okay. So if you don't agree, say that you don't agree. If you agree, say you agree lah. Obviously, yeah, you need to agree with what I said. So asthma is a chronic reversible large airway condition. When we say reversible, means that the child need to be on bronchodilator to know whether the condition is reversible. So kalau they've been on suboptimal nebulizers, suboptimal inhalers, and there's no improvement, how are you going to know whether there is improvement or not? So you need to do the peak expiratory flow rates, and he is 12 years old. So kalau katakan masa dia tengah wheezing, masa dia tengah coughing, dia punya peak flow dia 120, and then when you give the bronchodilator, regardless whether it's nebulizers or inhalers, then you should see an improvement of the peak expiratory flow rates. Normally you expect by 50%. So kalau lah 120 initially, then you expect the peak flow will be about 180. So that's about 50% improvement from there. Okay, so those are the things. The question now, has he got asthma? Okay, because if he's not got asthma, then the statement of underlying asthma is not a right definition to diagnose this chronic cough. Okay, so those are the questions that you need to think about. Okay, the thing that putting things more in place, why this child pointing out towards one possible ataupun one likely diagnosis is because he's coming from Burma. You guys know where is Burma?
Myanmar.
Okay, so Burma is Myanmar. So Myanmar is a new name, Burma was the old name. So he's been as a refugee. The issues now, we don't really know his vaccination history. So he might not be vaccinated against TB, ataupun tak pernah dapat BCGs. And he's probably been exposed to TB, regardless of whether he has whether he's been vaccinated against BCG or not. So those are the question now. But obviously, in this case, we don't give you the information about vaccination. But you know that this child has chronic cough. This child has poor weight gain. Losing weight. And this child also coming from the high risk groups population in Burma. It's the same as Thailand, same as Malaysia. So it's basically pointing out towards PTB. So PTB can give you chronic cough. PTB can give you weight loss. PTB can give you poor appetite as well. And poor appetite could lead to anemia, could lead to lethargy, could lead to a lot of things. And plus, dia punya mak dia also been coughing as well for a long time. So this all leading to PTB. So you don't need to mention that acute asthma secondary to PTB, because this is what TB is coming with: long cough, chronic cough, weight loss, and also poor appetite. The question now, is it something else that can cause a lose weight loss or poor appetite? And it could be orang kata partially treated pneumonia ataupun untreated pneumonia. That's why he's been coughing a lot for a long time. Why it's only at night? Probably because he's been living in the damp bedroom or bilik yang quite apa namanya dalam bahasa Melayu, damp in Malay. Oh dear.
Lembab.
Yeah, bilik yang lembab. Oh dear. I used to speak Kelantan, so I don't really know the Malay words. So bilik yang lembab can also induce a lot more hyperactive airways. Especially kalau bilik tu ada macam kulat kan, ataupun kita panggil aspergillosis. So sometimes fungal can also give you chronic cough as well, and fungal infection, fungal pneumonia is so difficult to treat as well. So sometimes you need to be on the antifungal medication for a long time before you treat fungal pneumonia. And obviously fungal pneumonia tend to be associated with immune deficiency, patient with leukemia ke, on chemotherapy, on a prolonged steroid medication and so on. So those are the questions you want to ask. Has the child got any other past medical history? Has the child been on any immunosuppressive medication, methotrexate, chemotherapies? Has the child got any immunosuppressive illness like leukemia, ataupun aplastic anemia and so on? So those are the questions that you want to ask. Does the child got primary immune deficiency? So those are the things you can ask. I agree with you about possible severe gastroesophageal reflux. Also can give you chronic nocturnal cough, where you need to see the pattern of the cough. Does the child only cough at night, or does the cough also happen during the daytime as well, but more worsen at night? So because if you got TB, people with TB, they cough every day and every night. Morning or afternoon or night doesn't make any much difference, apart from sometimes TB make the cough worsen at night. Okay, with the severe reflux, they tend to have cough at night, because when you're lying down, so you got reflux into your esophagus and then affecting your throat. So that's why you cough and cough and cough. So it's still possible as well. But normally they will also come with indigestion feeling as well after eating. And things get worse if you eat spicy food or makan pedas, that make things worse as well. I agree with Ishman about possible cardiac condition as well. So you might have congestive heart failure where you got pleural effusions, pulmonary edema, and then that also come with cough as well. But normally you also want to know whether the child had any cardiac condition or past history of heart problems. You also want to know, is there any puffiness around the eyes, the ankles, around the sacral areas. So those are the sign of congestive heart failure. You also need to also ask a question about shortness of breath on exertion. So you want to know the exercise tolerance. How far can he walk without stopping? Can he play as usual without stopping? But in this case, he's been mentioned that he's too tired to play games with his sibling for the past 4 weeks. So whether it's a heart condition or whether it's the poor appetite and also losing weight that make him less playful than usual. Okay. So far you got PTB, you got the gastroesophageal reflux, you probably got a recurrent chest infection or untreated chest infection. So for example, it could be streptococcal or it could be fungal infection. You're talking about immune deficiency condition like PID, leukemia, or if they've been on any medication, methotrexate, prolonged steroid medication, and so on. Okay. The weight loss, you can also talk about, has he got any sign of possible diabetes mellitus type 1? Okay, because his age 12 years old, still quite still in the category of possible to have type 1 diabetes. So you want to know whether any sign of any symptom of polyuria or polydipsia, polyuric at night and also polydipsic at night as well. You also want to know, how much he's been losing, any family history of diabetes mellitus as well in their family. So and sometimes newly diagnosed diabetes presented with prolonged infection problem, like if they might have prolonged unresolved fungal infection, prolonged unresolved cough. Sometimes they can have UTI as well as part of presentation for newly diagnosed diabetes. So this case possible that it could be type 1 diabetes as part of your differential diagnosis. So those are the things that I'm putting the idea here that you need further question that you need to ask. And obviously, if we have more information about his father, why his father died last year, that will be much more helpful, because the father might die from TB as well. So those are the things. And then Faiz was talking about possible endocrine condition. So why do you think what question you want to ask about endocrine conditions?
more to diabetes.
Because
More to diabetes already.
anything that lead to weight loss?
Yeah, hyperthyroidism.
So what the question? So you can ask about question about hypothyroidism then.
Presence of tremor. Patient has a tremor. Then, what's it called? The neck swelling. Any sign of neck swelling?
So yeah. So any question about that? So especially talking about hyperthyroidism, because of the weight loss, tremors, heat intolerance, neck swelling, apa lagi, palpitations and so on. So plenty of other questions to ask about hyperthyroidism. Okay. So any other differential diagnosis that you might think of? Okay, so I think that's probably all that you can think about, unless you want to put more like anorexia nervosa. So because he's got poor appetite, that's why he's losing weight. But obviously, anorexia does not really explain the nocturnal cough. However, if you got anorexia nervosa can induce primary ataupun can reduce your immune competency. So you probably have infection or prone to infection if you have anorexia nervosa. Okay, so those are the questions you can ask about. So you want to know what the eating pattern there. So does he eat and then he induce vomiting, which is symptom of anorexia, or does he control his diet, mean that he got very self-conscious about his body image, so he start to do extreme diets where he lose weight as well. And you also want to know whether he has any depression ke ataupun memang ada mental health problems that might that might lead to anorexia nervosa. So those are the questions you want to ask. Okay. Okay. So before I proceed with the question, anyone want to ask any question? Anyone? No question?
Maybe is it possible for this patient to have two separate diseases that lead to loss of appetite? Another one disease lead to loss of appetite, and another disease lead to chronic cough.
Well, if you're talking about possibility, everything is possible. Cumanya it's a bit orang kata apa, very unlucky lah if you have two separate conditions that cause the problem. So normally the problem orang akan dapat satu benda je dalam satu masa. Jangan dapat dua benda at one time kan. So it's a very unlucky person kalau dia ada two things at the same time. Okay, so I'm putting up the physical findings there. Okay, have a read. Okay, so he's a very thin child, very thin. Dia punya height dia not too bad, which is 75th centile. Dia punya weight dia is only on the 2nd centile. The heart rate is normal. The respiratory is not too bad. Slightly, I would say slightly tachypneic. Oxygen saturation is okay. There is no wheeze. Dia punya vocal breathing dia There is bronchial breathing on the right upper zones, which is suggestive of infection. There is no lymphadenopathy, and the rest of the examination are unremarkable. So what do you think?
Maybe TB.
You can say TB. What else? What else can you say? You can say it's a pneumonia, isn't it? Because it's a breath sounds on the right upper zone. Okay, what else? Could it be? I think I'm going to remove this.
Malignancy boleh ke Dr?
Okay, so you could say malignancy. What kind of malignancy that give you bronchial breath sounds on the right upper zones? So what does bronchial breath sounds reflects?
Consolidation. Yes.
Consolidation, isn't it? So infection somewhere there, isn't it? Ataupun consolidation lah, mainly. So if you're talking about malignancy, what kind of malignancy that give this kind of bronchial breath sounds? Ada? So it's basically anything, any mass or any lymph nodes that probably swell around the area. So you're talking about possible lymph nodes ataupun kita panggil apa tu?
Lymphoma.
Yeah, it's kind of like lymphoma ini. You're talking about mass around the areas of the chest that lead to breath sounds in the area. So normally lymphoma or leukemia, if you got a big lymph node enlargement around the chest areas, I need to find that particular term, and it can give you the bronchial breath sounds. Okay.
Mediastinal.
Yes, mediastinal mass. Yes, that's what I'm looking for. Who was that? Aina again. Okay. Tadi tak nak jawab Aina. Okay, fine. So if you got mediastinal mass, that also can give bronchial breath sound. Cuma bronchial breath sound normally we expect more inflammation ataupun infection around the areas. The other condition that can give you bronchial breath sound ataupun infection on the right upper zone, it could if you have severe refluxes. So if you've got severe refluxes, your food will go up to your esophagus, and sometimes because of the right bronchus is a very quite menegak. So the food can go into your right upper lobes lung very easily. So somebody who has aspiration pneumonia, we always if you got somebody with right upper zone collapse ataupun consolidation, you always think about aspiration pneumonia. So sometimes severe reflux can lead to right upper zone consolidation. Okay. So this is the punya X-rays. Can you see? Okay, so so somebody need to comment on this. So I need to find somebody. Jadi Afifah dah buat dah. Apa lagi yang ada? Suhaila kan? Suhaila dulu ni kan? Mana Suhaila?
Yeah.
Okay, so can you comment on the X-rays?
I can see the right upper lobe consolidation.
Okay, what else can you see?
And there is a cavitation over the right upper lobe.
Semua orang nampak kan there is possible cavitation looking round lesion on the right upper lobe kan. Apart from the right upper lobe, right upper zone and also upper lobe consolidation, there is also it looks like cavitation on the right upper zone yang near clavicular. Semua orang nampak kan? Okay. So the cavitation is almost the pathognomonic for TB. So in this particular case, you really want to rule out TB in this case. So you will do acid so gastric aspiration for acid fast bacilli. If you also want to do mantuk test as well. Okay, if your center has good resources, you also can send quantiferon for TB as well, but it's a very expensive test to do anyway. Okay, so this is just a further history that you probably need to ask. With the history of weight loss, with the chronic cough, you basically need to treat as TB until proven otherwise. So it's almost a TB, your provisional diagnosis until unless if you do all TB tests and it's all come back negative, then that's different. So you need to ask about past medical histories, family histories, and direct contact with tuberculosis. You also want to know about the father, but in this case we don't really want to tak dapat further question ataupun tak dapat further information. Well, no, sorry. I think in this case, the father actually died in Afghanistan. Ikutkan the history sebenarnya, mak dia kahwin dengan bapak dia orang Afghanistan, who then live in Burma for a long time. Apparently, bapak dia died from TB, where looks like TB because they're coughing up a lot of blood. Dia punya history of vaccination for Ihsan, mak dia tak sure whether they have TB or not. But you can look into your examination whether this child has BCG scars or not. Okay. Obviously, you ask further question about blood stained sputum, any chest pain, any dyspnea, any things that can make things worse, things that can make it better, weight loss when you first started, any diarrhea, any vomiting, any abdominal pain, any sign of possible steatorrhea, which is malabsorption punya ni. And also you want to know about signs of night sweat atau history of night sweat. So this is a further question you want to ask. I just put in here causes that you can consider for the weight loss. So inadequate nutrition ataupun memang tak makan langsung or on diet. It might be because he's been traveling ataupun refugee from Burma. So probably the food access is not great. So that's why he has inadequate nutrition. It could be that the parents been neglecting him to give some food. Refluxes or severe refluxes. Celiac disease is not common in Malaysia. Even IBD, inflammatory bowel disease, is not common as well. Cystic fibrosis, as your colleague mentioned before, is about failing to thrive rather than weight loss. The thing is, cystic fibrosis is very, very rare in ASEAN population ataupun Southeast Asia. And cystic fibrosis tend to present when they are small, not really at this age. So normally you expect the cough happening very early in life, probably a couple of months. Sometimes they can have what we call it mecanim ileus, where the child has not passed any mecanim at all. So those can happen in the first 2 to 3 days of life. So cystic fibrosis normally tend to be diagnosed very early in life. Anorexia nervosa, cardiac failure or cardiac disease, chronic renal failure, that one also can give you a sign of weight loss and also failing to thrive, diabetes, malignancy, and also infection. So these are all the causes of weight loss. So the chest shows dense consolidation with cavitation on the right upper lobes. Most likely it's a PTB. Fathers most likely die from the PTB as well. Mak dia most likely has PTB because she's also been coughing as well. So what you need to do with this boy is you need to admit for investigation and treatment. And treatment for TB is a long treatment. It's a couple of months treatment. The thing is you need to have this the type of organism that can cause TB, because because nowadays there's a lot of multi-drug resistant TB organisms. So that's why normally in TB you give 4 types of medication, not just kalau macam streptococcus you give 1 antibiotics and so on. But TB you need to attack in a very different way. So normally we combine with few medication to treat TB. Okay. The gold standard for TB diagnosis is culture. So you need to get the sputum culture, you need to get the gastric aspirate, send for acid fast bacilli. You also can do tuberculin skin testing, but sometimes you can have false positive or false negative result from that. The best way to do it is by doing interferon, which is interferon gamma from the blood, to look for the mononuclear cells that is responding to antigen from TB. However, interferon is a very, very expensive test to do. And the reason that we really want to get sample from him is because we want to know what is the sensitivity of this microorganism to the medication. Okay, so standard treatment for TB is isoniazid, rifampicin, ethambutol, and also pyrazinamide. And obviously, you need to know the side effects. Isoniazid can give you peripheral neuropathy, so sometimes you refer to ophthalmology to monitor their eyesight. And obviously, there is other things that can cause, like red urine, orange colored urine as well. Sometimes it can cause peripheral neuropathy. There's few other things, complication from a medication that you start with. And obviously, you need to notify if there is TB, if you suspect this is TB. So you always need to suspect about TB in a children with a high incident country. So regardless where you are, Malaysia ke, Thailand ke, China ke, Vietnam, Laos, Burma, and so on. If you got a chronic cough, you always need to think about TB. Okay. The likelihood of obtaining positive sputum smear or culture in children with PTB is basically not that high compared to adults. It's probably because it's difficult to have a good sputum culture, a good sputum sample from children, and sometimes it's so difficult to do a gastric aspiration in children. So that's why we have a much lower positive yield in children compared to adults. Okay, and then we diagnose TB based on the history and also exposure. Clinical findings, X-ray looking, and also a tubulin test ataupun mantut test. But obviously, if you can do interferon gamma, then that also will be included in part of the criteria for TB. So normally, if you got tubulin ataupun mantut test negative, but you have a good exposure, mana history memang exposed to TB, clinical finding pun nampak macam TB, X-ray pun macam TB, so you treat this as TB. Although the mantuk test is negative. Okay, any question?
Doctor, I read that for treatment of PTB, you need to take the medication in front of the medical healthcare staff, doctor.
Well, if you really don't trust their medication compliance, then you need to do that lah. Tapi the onus should be on patient. So patient should take care of themselves. But sometimes kalau kita rasa dia memang susah nak comply dengan medication, then it's better mana kena suruh dia pergi KK lah, and then take the medication kat KK. So I think some KK do that, but not all KK doing the same thing lah. Okay.
Doctor, another thing.
And then normally mild injury. Okay. Sorry.
It's about also the medication. I also read about breaching medication, breaching. So can you elaborate more about that?
Well, I've not heard about bridging medication. I don't know what is bridging medication.
Bridging.
Oh, bridging medication. In what context?
Never mind. Maybe I misread it.
Tak tahulah, kalau maybe kena tanya orang lain kot. Bridging medication, not so sure what is bridging medication. I think that's all. It's all technical term. Whether breaching like breaching, not taking medication, ataupun not complying with the treatment. So I'm not so sure what does it mean. I've not heard about term of breaching medication. So I think it's probably just a technical term. It's not something to do with pathology ke apa ke.
Doctor, in PTB, is there any chronic nocturnal cough? Because just what you said that PTB cough every time.
Yeah, PTB does not really cough at night. Yeah, pulmonary TB normally cough anytime during the daytime. Okay, the reason that kenapa kita we mention more about chronic nocturnal cough is because that if you got habitual cough, you only cough during daytime or when you are awake. The reason that we put nocturnal cough is because if you got TB or if you got infection, you will cough at night. If you got habitual cough, you only cough when you are awake. You don't cough when you are asleep. Okay. At the same time as well, nocturnal cough, it could be due to the severe reflux. So they don't cough during the daytime, but they mainly cough at night. So you want to know the pattern of coughing. So kalau pattern of coughing dia memang during the daytime je, tak ada langsung at night, then it's probably not really infection. It probably just habitual. Kalau dia cough during the daytime and also cough at night time, it's probably infection. If they only cough during the night time but not during the daytime, then it's probably TB or reflux, or it could be congestive heart failure, because when you sleep, the fluids is distributed equally to your lung, and so sometimes you got shortness of breath, and sometimes you can cough because of that.
Doctor.
Okay. Boleh So case one, everyone is agreed. Everyone have no more question.
Doctor, does BCG really protect us from TB?
Okay. So anyone want to answer that question?
No.
Okay.
It just a prevention.
Okay. So it's more of towards
herd immunity.
Herd immunity. So you want to protect the herd immunity. So that's why you vaccinate everybody. There is no such thing as 100% prevention. Mana there will be mana kalau if you got 100 patient yang 100 babies yang been vaccinated against TB, probably one or two of them will have failed of vaccinations. Mana dia mungkin ada scars, tapi probably dia punya immunity dia not that high. Ataupun when they do the vaccination, mungkin teknik tu salah ke menyebabkan dia punya primary vaccination tu does not really develop properly kan. So there will always be a failure rate for vaccination. You cannot expect 100% effective. Sama macam influenza kan. Influenza, it does not really prevent you from getting influenza, but it will reduce the severity of influenza when you get it. So you cannot believe of 100% effectiveness, but you would accept probably 90%, 85%, 90% effectiveness of vaccinations. So there will be cases of TB, but the most important thing is you want to develop the herd immunity when you develop any kind of vaccines. To be when you're thinking about national vaccination schedule. So same now as streptococcal infection and pneumococcal infection. So government nak introduce pneumococcal vaccination as part of the national vaccination schedule. The reason for that is because you see a lot more pneumococcal pneumonia nowadays. So especially in children. So the other is try to give the vaccination to the 2020 punya babies. Hopefully in the next 5-10 years, our population will develop the herd immunity, and then by time the cases of pneumococcal pneumonia atau pneumococcal sepsis will reduce because of the herd immunity. Okay. All right, next case.
Okay.
Siapa buat next case?
Saya.
Okay.
So for the next case, I will read the triggers. Okay, Sami, a 9-month-old boy, has been referred to the community pediatric clinic by his health visitor because his head circumference is on the 99.6 centile. He was born at 30-week gestation by spontaneous vaginal delivery, following an uneventful pregnancy to a someone woman. His birth weight was 4.3 kg and his head circumference at birth was 38 centimeter. This is the mother's third baby, but the other two children have a different father. Sami doesn't sleep very well, waking up to 3 times per night, and this was the main reason his mother went to see her health visitor. Sami is otherwise well and has not had any previous medical problems. He has been able to sit unsupported for the last 2 months. He crawls. He can use either hand to pick up raisin or grains of rice. His mother has no concern about his vision or hearing, and he passed his newborn hearing screen. He is still breastfeeding, but also eat pure and finger foods. The mother, her partners, and the 3 children live in a 2-bedroom flat. So, from these triggers, I would point a positive point, which is Sami, a 9-month-old boy, with head circumference 99.6 centile, and born via SVD at 38 week of gestation. The birth weight was 4.3 kg and the head of circumference was 38 centimeter. And he doesn't sleep very well and waking up for 3 times per night. And okay, the others are normal. Okay. So the main complaint here was Sami doesn't sleep well and frequent waking up 3 times per night. And before that, I would like any of you to comment on the head circumference, 99.6 centile. Is it normal or not for 9-month-old boy? Anyone?
I think not.
Okay.
Hello.
Hello.
Because I read that is microcephaly is defined as more than 98 centile.
So you think in this patient might have microcephaly. So what about his birth and his circumference during at birth? What do you think? Is it normal or not? Anyone? Raja?
Yes.
So what do you think about the birth weight and the head of circumference of this baby during at birth?
I think so. It's not normal.
Yes. The baby weight is quite heavy.
90 percentile.
Yes.
It's above normal value. I think so. 4.3 kg berat ke?
Yang from what I read, yang normal until 4.5 G.
Yes.
4.5.
Oh, the normal one, it could be 3.5 kilogram. But this patient had 4.3. It's quite huge.
Do you guys know what is Samoan?
Samoan, no. We got Sarapian.
Ethnic
American Samoan.
Samoan.
Samoa.
Macam The Rock. The Rock.
So
Ethnic.
it's Dwayne Johnson, The Rock. So those are Samoan. So it's a ethnic dekat Amerika ke kat mana? I don't know. So
Hawaii.
Hawaii.
Doctor, is there any significance in regards to the ethnicity?
Yeah. So most of if you Google Samoan, so most of the Samoan is a big obese kind of people.
Oh yeah.
So okay, carry on.
Okay. So anyone have an idea? So what the possible cause of the macrocephaly in this patient?
First of all, we need to confirm first the father's head circumference to know whether it is normal or not. Familial or
Okay. So anyone else? Nourishment?
Anybody else? So you need to think about differential diagnosis in this case. So
I think
Yep. So always think about always think about what could be the differential before you go further. Okay, and I think apa tadi siapa cakap ni? Raja cakap pasal measuring the head circumference. So it's not just the father lah. You also need to measure the head circumference of the mom as well. Both measurement need to be taken. Okay, because if it is familial, then you expect both mom and dad will have big head as well.
I think we need to divide the diagnosis according to the condition of the baby, because in macrocephaly, the big head can be divided into microcrania, hydrocephalus, and also megalencephaly. In macrocrania, there is increased skull thickness due to bone metabolism and also hypertrophy of the bone marrow. And in hydrocephalus, there is enlargement of the ventricle of the brain. In megalencephaly, there will be enlargement of the brain, maybe due to disorder of the brain development and also accumulation of abnormal metabolic function. And the last one is due to the family trait that is explained by Raja just now. And I think this baby has hydrocephalus, and the condition of Sami doesn't sleep very well, waking up 2 to 3 times per week because of
Tak dengar lah.
Hello? Because of?
Oh, maybe.
Because of?
I think she has absence seizure just now. Okay, fine.
I think because Maybe hydrocephalus too because of high intracranial pressure.
But the question now is it really hydrocephalus? It says that Sami doesn't sleep well, waking up at night 3 times per night, and this was the main reason his mother went to see the KK has visited ni macam klinik macam macam community jururawat community lah, jururawat masyarakat has visitors. So is it not normal for 9-month-old to wake up at night 3 times per night?
Normal je.
Normal je.
Because I got a 13-month-old baby in my house. She works at night twice, at least twice. The most probably 4 times. Just breastfeeding or feeding. So I didn't see this doesn't sleep well at night, waking up 3 times. For me, that's quite normal for a child. As long as they go back to sleep after that, adalah they're waking up at night and they stay awake for or crying. So those are different kind of problems. And betul tak Samba?
Betul.
Okay. Okay. So anything else you want to ask?
So what is the chief complaint?
So what is the issue?
So what is the chief complaint? Betul tak? So siapa nak jawab ni? Apa? Najla bukan Najla, sama sikit. Najla yang present. Okay. So what is the chief complaint? What is the chief complaint?
Big head.
The head
So who are actually concerned about this child?
Mother.
Is it mother?
Mother concerned about
the
sleep.
Community pediatric clinic.
Especially mak dia concern pasal dia tak sleep well je. Yang start referring is basically the health visitors tu yang start referring. The health visitor yang worries. So that's why they refer. Basically they check, tengok kepala dia besar kan. And that's why they refer to the community pediatric clinic lah. Because the referral has been done by the health visitors because of the head circumference. That's the chief complaint. Okay, his complaint is not coming from the mom. His complaint coming from the health visitors. Faham tak? So that's the chief complaint there. Cuma in this case, it's not coming from the parents. It's coming from the health professional. Okay, Faiz. Okay, Faiz. So
Okay.
Itu dia punya chief complaint dia. Mak dia basically nak dapatkan ni je, nak dapatkan attention je yang anak dia ni tak tidur malam. Boleh tak tolong jagakan anak dia? Contohlah kot berkurang kan. It's like when Raja was small, he's a very he didn't sleep well, so mak dia pergi ke pengasuh dia, boleh tak tolong jaga anak saya kan. Betul tak? Ya.
Berkurang lah.
You see? So okay, so what other question you want to ask? So now you need to think about genetics. So it's a family trait as siapa cakap tadi?
Raja.
Yang cakap banyak tadi.
Daya. Because of.
So she mentioned about the family trait ataupun genetics. She mentioned about macrocephaly. She mentioned about hydrocephalus, and then she mentioned about the other one is
megalocephaly.
Okay, so those are the distribution ataupun macam orang try to categorizekan the causes of big head. So if you're talking about macrocephaly can also be genetics, can also be familial, and it can also be pathological. So kalau macam genetics, macam apa, if you're talking about Sotos syndrome can come with a big head. If you're talking about
Fragile X
syndromes, banyak lagi lah benda lain, cranial synostosis also can cause macrocephaly as well. Hydrocephalus is something to do with the ventricles. Okay, and then when you come to the encephaly, it's more of the brain structure. So sometimes megalocephaly also involve the excessive production of CSF fluids as well that can cause megalocephaly. Okay. So this is the examination findings. The most important thing is Sami looks very well. It's a very well child. He's smiling, he's bubbling. So for 9 months old, that's fine. And the main thing, he's not dysmorphic. His weight there, 9 months old, 10.5 kilograms, which is a big baby for 9 months old. His length is okay, 92, mana dia besar dan tinggi. His circumference 99.6 cm. Okay, and then the rest of the measurements are normal. Okay, so that's not much really in terms of physical finding dia yang very concerning. Cuma ya, bila kita tengok dia punya kepala dia, compare dengan badan dia punya sental tu difference lah. So that's a concern. So what actually caused this big head? And so anybody with big head, you always want to make sure that there's nothing wrong with the brain. Okay, so kalau dia ada hydrocephalus, then you can treat hydrocephalus with VP shunting. But if there is any metabolic condition normally come with a baby which does not really progress in terms of their developmental milestone. Normally they have developmental delay and so on. If they got syndromic, then normally you have dysmorphic features. Okay, what features in the history to help distinguish between the causes? So that's fine. I think I'm just going to go through further about this question. So if you can read about this, so last hit, obviously, before we come to the normal variants, we want to do a proper assessment and proper investigation. Anyone yang ada big head, especially in children less than 2 years old, you really want to investigate first. Okay, investigation dia normally you assess dia punya developmental milestone lah, making sure that the child is developing normally, tone dia okay, power dia good, reflexes is present, and so on. You also want to make sure that their social skills, their gross motor, fine motor, the language also developing normally as well. Okay, and then obviously you will want to get involved with want to request radiological investigation. If the head ada lagi dia punya open fontanelle, then you will do the ultrasound. Kalau fontanelle dah already closed, then you probably can request for CT head. And cuma ya, if the child looks normal, as you mentioned normal, and then all the developmental milestone all normal, you don't need to do urgent CT. You probably can wait and see first. Mana wait and see, mana you can live for about 6 months, probably 1 year, just to see the pattern. Okay, so if the child looks well, dia developing normally, then you can always delay the CT to at some later age, maybe 2 years, 3 years, and unless if they develop signs of raised ICP, so hydrocephalus, maybe kalau ada tumor and so on, which is probably unlikely, then obviously you need to do urgent CT. So kalau macam hydrocephalus, you will see sign of sunsetting eyes, suture dia still quite wide and gaping. Obviously the developmental milestone also delayed as well. So those are the time when you want to do the urgent CT, because that would be life-saving and also brain-saving procedure as well. So obviously if you got something in the brain, the pressures in the brain will raise very rapidly. So that's why you will see more sign from there. So kalau in the bigger kid, they normally come with lethargy, vomiting, nausea, and loss of appetite. And sometimes they can come with irritability as well. So they are cranky all the time and they don't want to play and so on. The other thing is, if you see a child that is developmentally normal initially and suddenly they lost their development, so macam kita panggil regression. So you need to think about metabolic condition, genetics, and also syndromic causes at this time. And if you see a child yang ada big head tapi ada lot of injuries, lot of bruises, then always think about non-accidental injuries. Okay, so if there is concern about family punya dynamics, for example, single parents ke, single mom ke, so those are possible that there might be some sort of shaken baby syndrome, physical abuse and so on. So those are the things that you need to think about. A child that come with fitting, especially for those under less than 6 months, if they come with fitting, mana kita panggil Afiba fit, at the age less than 6 months old, you probably want to do imaging, especially CT brain, very early, because it could be the sign of metabolic condition or a sign of bleeding in the brain, or it could be meningitis that can cause that as well. But obviously meningitis does not really give you big head. It tends to give you tense fontanelle or rest fontanelle or bulging fontanelle. Okay, so I will list down the causes for macrocephaly, but obviously the main thing about this case is about examination, making sure you are looking at the shape of the head, size of the head, and looking at the fontanelles. You also want to see is there any sign of neurocutaneous lesion macam cafe Aole ke, birthmarks ke, ataupun Sjogren patch and so on. Okay, you also need to think about whether this could be kita panggil neurofibromatosis as well, because neurofibromatosis also can cause a big head as well. And always measure the head circumference of both parents. Okay, so this is kind of causes of macrocephaly. So hydrocephalus normally it comes with tense fontanelle, distended scalp veins. If there is any vascular malformation, so when you auscultate the fontanelle, you can hear the cranial buoy. Normally we don't really do this, and sometimes it's quite rare to see a vascular malformations. If there is any tumor, then it normally come with abnormal signs of neurology, vomiting, or nausea. They might have raised ICP as well. They might have eye signs like squint or sunset eyes. Kalau the hematoma or subdural hematoma, sometimes you see with bruising or physical abuse, Fragile X syndrome, neurofibromatosis, Sotos syndrome, where you go overgrowth of the syndrome, but normally it comes with developmental delays ataupun other part of the body also quite large as well. Metabolic condition like mucopolysaccharidosis like Hurler syndrome or Hunter syndrome, but normally it comes with cross features like you might have tips lips, might have a short nose, you also might have deep sunken eyes and so on. And obviously there's familial macrocephaly where both parents are macrocephaly, tapi normal developmentally, and there's no sign of dysmorphisms. Okay, so even though Sami has big head, tapi dia punya normal development, dia punya growth chart dia is not too bad, and obviously the changes because dia punya head circumference dia masa lahir already 98 centile, and then now at 9 months it's 99 centile. So in terms of difference of centile, it's only one centile difference. It's not crossing 2 centile. So that's why and we don't really be alarming at this stage. But obviously you need to look at the whole picture. Kalau dia memang tak normal developmentally, dia punya body size and dia punya weight and height dia memang let's say 25th centile, cuma kepala dia besar, then you need to think about doing imaging almost immediately. But looking at the height, the weight, and the parental head circumference is probably not really alarming in this case. Okay, so the most commonest big head in children is basically familial. However, before you put down the familial macrocephaly, you need to make sure that you assess properly. So make sure that you assess the developmental, the histories, the growth charts. Make sure that the patient has no signs to suggest risk ICP and so on. If you are in doubt, you can always Manakala kalau dia ada open fontanel, you can always do a ultrasound scan first of the cranial. If you really dealing with a very anxious parents, so parents dia memang very anxious kalau tak buat CT scan, then they probably will come back to you to get more and more advice. Then you probably can do a CT scan, but you don't need to do urgent CT scan. You probably can wait for some point before you request a CT scan. But obviously you need to think about red flags if there is any symptom or signs to suggest any intracranial pathology, as I mentioned before. Okay, anything else you want to ask?
Doktor, kalau genetik boleh ada complication ke?
So if the microcephaly due to the genetic condition like Sotos condition, mana dia ada overgrowth of the growth plates, kan? So in that particular case, it does not really cause problem to the brain itself. Cuma because it's a genetic condition, sometimes it will affect their punya learning abilities. They might have whatever lembam ke, slow learners ke, so developmental milestone probably delay as well. So because of that, the features of Sotos is developmental milestone delay, and then dia memang structure dia memang quite big structure. So big head, probably long hand, long feet as well. If you look at the neurofibromatosis, okay, neurofibromatosis, you can have this fibromas anywhere in the body. So on the nerve roots, in the brain, and so on. So sometimes neurofibromatosis, especially in case of tuberous sclerosis, you got tubers anywhere in the body. So sometimes this tuber can cause microcephaly as well. So in that particular case, the child might develop seizures, the child might have a developmental milestone problem, and so on. So it's all depend on what causes the microcephaly. Okay, kalau if you got neurofibromatosis, you will need to refer to the neurosurgeon. Neurosurgeon because sometimes they might have problem in the brain ataupun ada fibromas in the brain that might need to be removed, because that could be the reason why they have big head, because they got raised ICP, and then you probably need to remove that fibromas. And sometimes fibromas can happen anywhere in the body that need to be removed as well. So it's all depend on what causes the microcephaly. Kalau dia cuma ada familial microcephaly, then you don't need to do anything. Maknanya that's him. He will live normally. Okay. The other thing is sometimes hypothyroidism also can cause macrocephaly. So in that particular case, you probably just need to start on thyroxine as a hormonal replacement, and then see how the child progresses. Okay. Anything else?
Doctor, usually children with microcephaly yang others than yang familialnya ada developmental delay.
So rarely familial microcephaly ni ada developmental delay. Most of the time they are quite normal lah, dia punya developmental dia. So if you suspect somebody who has familial microcephaly, tapi dia ada developmental delay, then it's probably not familial, probably something else. Because somebody familial, maknanya kalau mak ayah dia memang besar, mak ayah dia normal, maknanya boleh bekerja macam biasa, very independent, and then tiba-tiba anak dia ada big head, tapi ada developmental delay kan. So most likely that babies causes of microcephaly dia not due to the familial microcephaly, it's probably something else. So in that particular case, you probably need to do CT scan, probably MRI as well. You probably want to do metabolic screening, probably want to do TFTs, thyroid hormone, and so on, to see what is actually the causes of the microcephaly. Because sometimes familial normally they are normal lah. I've not seen a familial yang tak normal. Normally they are normal. Alright guys. So ni group 1 kan? Group 1 semua hadir ke? Ada yang tak ada?
Hadir.
Semua ada Fine. Any other question before we adjourn our session? Okay, no question Okay, so I just want to ask your favor. So I've blast a questionnaire regarding coronavirus knowledge, attitudes, and also practice during the MCOs. So I would like to ask your favors to fill in the forms.
Done.
You done already. Okay, thank you very much. Thank you very much. So thank you very much for your help. Siapa maybe yang tak isi tu, you just remind your colleague to fill in the form. So we are hoping that we can reach about 900 response within 2 weeks. So because this is also involve USM and also UNIZA student as well. And then we can see lah siapa yang bagus, USM ke UNIZA ke ataupun UIA lagi bagus untuk knowledge COVID kan. Okay, thank you very much for your attention, for your attendance, for your participation. Oh, sambal demam. Tak sihat Batuk sikit. Kena swab tu. Pergi tonyo hidung sikit. Okay, so I think we probably have probably 1 or 2 more session discussion, but we can arrange that later. If there's no question, then we got the agenda session with Tasbih Farah as well. All right, thank you very much. Thank you.
Thank you, Doctor.
Thank you,
Doctor.
Thank you, Doctor.
Leave lah Najla.